As we celebrate the 10th episode of the monthly Medicinal Herbs podcast series, we welcome back naturopath and medical herbalist Berris Burgoyne to talk about heart health and herbal support for a healthy heart. For a long time, cardiovascular disease was thought of as an issue specific to men, but as Berris discusses in this episode, heart health is something to consider for everyone.
I'm excited about this topic tonight on heart health and cardiovascular disease. This is something that is really personal to me. I remember back as a little girl, my grandmother having cardiovascular disease and having a stent put in, and how fascinated I was with the heart. That was kind of the start of me thinking about nutrition. I'm excited today to have Berris with us tonight to discuss a little bit about this topic of cardiovascular disease and how we can modulate it through a variety of different herbal ways, and really to dive deep into the role of cardiovascular disease in overall health. So welcome, Berris. So great to have you again.
Thank you.
Berris, can you just talk a little bit about why this is such a major issue here in America, but really globally?
Yes, absolutely. Look, heart disease is a major health issue, particularly in developed countries, but, also in developing countries. It's a major cause of death. In fact, in the United States and in Australia, it's the leading cause of death in both males and females. So it's a very significant condition. So, when we hear things like that, we think, so what, almost, if it's not affecting us. But I'd like to paint a picture for you to really help emphasize the significance of heart disease. 1 in every 4 deaths in the United States is due to heart disease. And 1 person dies from some form of cardiovascular disease in the US every 36 seconds. And that's from the CDC, September 2020. Coronary artery disease is the most common type of cardiovascular disease, and this leads to ischemic heart disease, and of course that can go on to cause heart attack. In the United States, someone will have a heart attack every 40 seconds. Not everybody who has a heart attack dies from it, of course, but that shows you the frequency of heart attacks. Again, that's a figure from the CDC September last year. So you can see that it's a very, very serious health issue. And unless we take care of ourselves by avoiding or at least minimizing the major risk factors, but also implementing preventative factors such as exercise, adequate sleep, good diet, etc., it could strike any of us at any age. And most of us are aware of the things that we can do to minimize our risk of heart disease. But I think quite often we don't do it. We think, I'm fine, I'll do it when I'm a bit older. But the earlier we start doing these preventative measures, of course, the better. And I think it's really important that people understand the significance of it. So, 1 in every 4 Americans or deaths is from heart attack. That's, 1 in 4 of you, listening to this recording. So we need to take it seriously.
Can we talk a little bit about the risk factors? I think about oftentimes, heart disease was thought to be just a disease that, affected more men than women, but that's not the case anymore. So what are overall for both men and women, what are those risk factors?
Okay. So probably the most significant risk factor for cardiovascular disease is high blood pressure. So if you've got high blood pressure, you need to get it under control. Of course, high cholesterol can also be a factor, but I believe it's much more of a risk factor when it's associated with other risk factors for cardiovascular disease, particularly hypertension. Smoking is also a major risk factor, and fortunately, in recent decades, we've seen a decline in the number of people smoking, and hopefully that continues. But it's a major risk factor for every chronic disease. So it's something that obviously we shouldn't be doing. Obesity, metabolic syndrome, and diabetes are also very important risk factors. And if we exclude type 1 diabetes, these are largely driven by lifestyle issues. So they are avoidable and we can reverse them. So, the sort of lifestyle issues that will cause them or contribute to them is lack of exercise, an unhealthy diet, stress, particularly if we have elevated cortisol, and importantly, lack of sleep. And we have control over most of those things in our lives. So they are the most significant cardiovascular risk factors, but certainly hypertension is the most significant one.
As we talk about hypertension or high blood pressure, what is contributing to that for most people? Is it diet? Is it weight? What are really the key contributing factors?
It can be a whole range of issues. And look, I'd like to start with a really important one, but it's one that is often overlooked, and that is excessive alcohol consumption. And surprisingly, this was a surprise to me recently when I was looking at this, excessive alcohol consumption is defined as more than 20 grams of alcohol daily for women and more than 30 grams of alcohol daily for men. So what does this mean? A 5-ounce glass of wine contains 14 grams of alcohol, and that's assuming it's 10% alcohol. Most wines are probably between 12 and 14%. So that means that to get that 14 grams of alcohol, you would be having even less than 5 ounces of wine. When we see for women, excessive alcohol consumption is above that 20 grams, women can't have really much more than a 5-ounce glass of wine before they could be exceeding that. And that 14-gram figure is used because in the United States, 14 grams of alcohol is a standard drink. In Australia, it's interesting, a standard drink is 10 grams of alcohol. So we've lowered the limit of alcohol for what's considered a standard drink. I think it's important as practitioners that we let patients know this information, because often when we're talking to our patients about alcohol consumption and we say, how much do you drink? And they say, oh, I'll have a glass of wine each night or whatever. And how large is a glass of wine? Because 5 ounces is not a very large glass of wine. And often when we put wine into a glass, we put a fair amount in. And so we need to know how much wine that wine glass holds. Other things that are important are high sodium diet, but also a low potassium diet. And both of those can contribute to hypertension. And a really important one is poor sleep and also obstructive sleep apnea. Now we're seeing, I think in our patients and in our communities generally, more and more sleep disturbance issues. And there's huge amounts of research done on this now. We know that lack of sleep is an independent risk factor for hypertension. And individuals that have short sleep duration have a higher incidence of overall cardiovascular disease. And when we're talking about blood pressure, it's really interesting to note that blood pressure actually has a diurnal pattern and it falls at nighttime. Now, there's some people that don't have this natural dip in nighttime blood pressure, and they are called very scientifically non-dippers. And they have a higher risk for developing cardiovascular disease. So if we're not sleeping well at night, if we're not getting enough sleep, or we have disturbed sleep, or if we don't go into the deep sleep patterns that we should be going into, then our blood pressure probably won't have that drop, and that will have a detrimental effect. But poor sleep also is a major risk factor for obesity, metabolic syndrome, etc. And I've already mentioned previously that these are risk factors for cardiovascular disease. So sleep is crucially important for our cardiovascular and our metabolic health. Dysbiosis also be a driver of hypertension. And this is particularly the case when you've got that dysbiosis in conjunction with obstructive sleep apnea. So we also have to look at the gut in our patients. And in fact, in patients with treatment-resistant hypertension, one of the most common causes of that treatment resistance is obstructive sleep apnea, which may not have been diagnosed. So we have to treat the sleep apnea rather than trying to increase blood pressure medications or add to blood pressure medications. That's where you'll get greater results.
I wanted to reflect back on first the drinking aspect, and we see specifically, I think binge drinking causes even more risk than casual drinking, right? And I think to your point, right, that many people don't understand even what that means. They think, oh, I have 2-3 drinks, it's not a big deal, right? But it can be a bigger deal. And so that kind of builds up that if I don't drink during the week, but then I go and I have 4 or 5 drinks, well, that becomes a real concern for our heart health.
It absolutely does. And in the literature now, I'm reading that binge drinking is defined as as 2 standard drinks.
Right.
On a regular basis.
Yep.
But even just standard drinks is defined as binge drinking. I was astounded. So, in the US, you've got something like a 5-ounce glass of wine, and that's about 140 mils, whereas in Australia, a standard drink is roughly, or wine is roughly 100 mil. And so that's, 2 standard drinks is not a lot of wine to be drinking, for example, but that is now considered in some circles as binge drinking. So we've got a lot more understanding of the adverse effects of alcohol now, and what a huge problem it is. Not because, everybody's an alcoholic, but because people are drinking far too much, far too often. And in Australia, I'm not sure if it's the same in the United States, but in Australia, the group that is of most concern to health authorities is middle-aged women.
Right.
And the amount of alcohol that they're consuming. I actually saw a documentary on this once where they were talking to women in this age group about how much they drank, et cetera, et cetera. And one woman actually said, I sometimes think, how did 1 glass of wine a night get to 1 bottle of wine a night? And I was just blown away by that. So that's a huge problem. We need to make our patients aware that, yes, they might be having 1 glass of wine a night, but how much wine is in that glass?
Yes, exactly. Finding other ways to, relieve stress, or, if that's why they're utilizing it. There's a lot of other opportunities. And I do think in the United States, it's that same, that those young moms or those middle-aged women, like we're seeing that issue too. The other point that I think was interesting was on sleep apnea. And we know a lot of times sleep apnea is so tightly correlated with weight, right? And so having that lifestyle approach with the sleep apnea is a really key thing too.
Absolutely. You have to get the sleep apnea under control, but often you have to, if the sleep apnea is caused by excessive weight, you have to reduce the weight. And it's harder to lose weight when you've got sleep apnea. So it becomes a vicious cycle. So really, the message is, in our patients, the sooner we start dealing with patients who are overweight or obese, the better, before all these things progress. And even in people that, are maybe not obese, but they're certainly carrying a bit of weight, I think it's our duty to say to them, look, you are carrying a little bit of excessive weight. And, the things that could occur. I think when we're dealing with adolescents, particularly adolescent girls, we need to be a little bit careful with that. We don't want to induce them to be having an eating disorder, but it's something that we do have to address. And I know my doctor said to me, I've had him as a doctor for a very long time, and he said to me a couple of years ago, he said, you're starting to carry a little bit of weight. I think you need to do something about that. And so that was a good message, because it can creep on and we know we're putting it on, but, it's easy to ignore as well.
Right.
So that was it for me. Yes.
As we think about hypertension, though, it's not just about the high blood pressure. It's about its effects on the heart as a whole. And can you talk a little bit about that?
Well, look, it has effects on the heart without doubt. And the reason that I said that elevated cholesterol is probably more dangerous in the presence of hypertension is that, we know that it's the cholesterol plaques that can cause coronary artery disease, etc. But the cholesterol is not going to bind to the endothelium of the heart and cause plaques. if that surface is nice and smooth like it should be, there's got to be some sort of disturbance to it, some damage to it. And one of the key things that will damage the linings, the blood vessels, is high blood pressure. And that's why I think that combination of elevated cholesterol and high blood pressure is definitely not a good combination. But hypertension can cause disease or damage beyond the heart as well. In the short term, we can see much higher risk of stroke, and that is a really high risk. And, you know, I've talked to a few doctors about this. I personally am very fortunate that I don't have high blood pressure, and it tends, if anything, to be a little on the low side, which always pleases my doctor. But, you know, I've talked to doctors about it, and they all say the thing that scares them most about high blood pressure is a stroke. Not so much a heart attack, that's bad enough, but a stroke is worse. It can just render you so incapable. So that's what scares them, and that's what they try and instill in their patients. But we can also see kidney disease, we can see higher incidence of dementia in hypertensive patients. There can be peripheral arterial disease as well, and in men there can be erectile dysfunction. So the effects of hypertension can be very widespread.
And I'm glad you brought up cognitive decline too, because I think that's something we don't always associate, right, with high blood pressure, but there's, you know, growing amount of evidence to support that too.
Absolutely, there is. And, you know, we know that exercise can help reduce hypertension as well as all the other cardiovascular risk factors. But of course, exercise is also very good to help reduce your risk of dementia. So the lifestyle issues that we talk about for something like cardiovascular disease or metabolic syndrome or whatever, they spread across a whole range of conditions, particularly the chronic diseases of aging. And that message, you know, especially about exercise, has been very clear for a very long time now.
If we think about some herbal options have an effect on hypertension, what would those be, and what would you recommend in that area for herbal support?
Well, my favorite herb for hypertension is coleus. And I use it in a tablet form, and I usually prescribe it about, you know, 1 tablet 3 times a day in most cases. So the dose of coleus that I'm giving daily is relatively high. It works out to about 16.5 grams of the herb. And, you know, I just find it so effective for hypertension. There's other things I use, but coleus is the go-to for me. And I've seen fantastic results with it in my hypertensive patients. It's also been shown to help with weight loss, which of course can indirectly help with hypertension. And the doses they used in the weight loss clinical trials, the coleus that they gave delivered around about 50 milligrams of the forskolin. So if you're using it for blood pressure, it may also help with weight loss and in particular fat loss. Another herb that I absolutely love for my hypertensive patients is astragalus. It has hypotensive activity, it has cardiotonic activity, which means it helps to nurture and protect the heart. And it's also an adaptogen, so it can help with the stress response, and that's extremely important. I often combine it with other adaptogens like eleuthero and ashwagandha. Sometimes I'll also add echinacea in there. We know that that will help with the stress response, but it will also help to keep the immune system up as well. And I think it can be an important herb in these patients.
Would you think about other ways to help with stress? Because we do know, and you know, we see that a lot in the current environment, that people are stressed, so that becomes a real part that they're wired and tired, and then has an effect also on their circadian rhythms and thus their blood pressure?
Oh, absolutely. Look, I think there's a lot of lifestyle things that people can do to help blood pressure. And certainly, you know, exercise is one of them. But, you know, making sure that your diet is fine, that it doesn't have high sodium or it doesn't have low potassium. And I just spend a lot of time with my patients talking about diet and talking about lifestyle issues. If they're highly stressed and they need to relax, I just say, what does help you relax? What is it? There's no point us saying to our patients, you know, you have to do yoga 3 times a week. They might hate yoga. They're not going to do it.
That will cause them to be stressed.
Yeah, that's right. For me, it's being out in my vegetable garden, pottering or working, doing whatever. That is the best de-stress for me of all. But it's different for different people. So I ask them, what helps you de-stress? And, okay, how can we incorporate that into your daily life? What can you do to help yourself de-stress? But beyond the herbs that I've talked about for hypertension, you know, I use a combination of herbs in my clinic that I think is just fabulous for that tired and wired person. And, you know, the combination is ashwagandha. It has some licorice in it as well, a little bit of Korean ginseng and some skullcap. So it's just ideal for that tired and wired person. For someone who's sort of highly stressed and irritable, which is not good for your cardiovascular health either, I might give them a combination with saffron and St. John's worting, for example, to help sort of calm them down and reduce that irritability. So there's other botanicals that we can use in these patients in conjunction with what we're using. I think if we're dealing with cardiovascular disease or if we're dealing with someone with hypertension, we have the herbs that we know will help with hypertension, but then we have to think about, well, what's contributing to the hypertension in that patient, and then how can we deal with that? If we can see that they're very tired and wired, well, then we can give them something like that combination I said with the ashwagandha in. So, you know, we have to determine what is it that is underlying the hypertension. And I think we have to be a little bit careful. Most of our patients are going to be stressed to some degree. I think we have to be a little bit careful about thinking, well, they're stressed and that's what's causing the hypertension. We also have to rule out other factors as well. And if we ask them about our sleep, if they have symptoms of sleep apnea, for example, they're waking tired or they're waking with headaches, etc., waking with a really dry mouth, then maybe we want to get them tested for sleep apnea, even if they're not overweight, because overweight is not the only cause of sleep apnea. Sometimes there's things that need to be fixed surgically with minor surgery. So you know, we need to rule out all of these factors in our patients.
If we reflect back on heart disease and specifically high blood pressure and all heart disease across the board, it was deemed a man's problem, right? A male problem. But we see now it is the leading cause of death. And I started, you know, the podcast off about my grandmother. I think that women continue and not to be, you know, affected by this. And it's affecting younger women as we, you know, move through time. It creeps down lower and lower. Can you speak a little bit about the specific, like, why do we see this shift, and how can we help women to be more aware of these concerns?
Thank you for that question. So this is my favorite topic, cardiovascular disease in women. And I do get, you know, on my soapbox a little bit about it, because it's just really not good enough what we're seeing most of the time. So the idea that cardiovascular disease is predominantly male largely comes about because up until fairly recently, every bit of research done into cardiovascular disease was done in men. And that included, if they were doing animal studies, they only used male animals. They didn't want to include women or female animals because the whole menstrual cycle and the fluctuations in hormones can skew results in research. So they excluded women, which seems astounding since the real world has women with fluctuating hormones. If it wasn't so serious, it's quite hilarious, I think.
Right.
A prominent female cardiologist a number of years ago was talking about this topic. She actually wrote a book on this topic, and she called it Women Are Not Small Men. And I think that just says it all, and I absolutely applaud her. She was just really talking about and being very critical of the fact that all this research has been done in men, and you cannot apply it to women. And as a result of this, the death rate for cardiovascular disease is actually greater in women than it is in men. But until recently, no one was thinking of cardiovascular disease as a women's issue. And in fact, when that change came about, and it's been slow, and in fact, when you sort of read the research and look at how women are still often treated in medical systems when they've got ischemic heart disease, there's still a long way to go. But things began to change slowly in the early 1990s when the NIH had their first female director, who happened to be a cardiologist. And she just basically said to them, this is not good enough. We have to change the way that we research heart disease, the way that we look at heart disease, because too many women are dying from heart disease and it's being ignored. She wasn't very popular, and she had a very difficult time amongst her peers. And I think she only lasted in that position maybe 18 months. I can't remember exactly. But we may not even be where we are today if it wasn't for her. So it's a huge problem. And it really surprised me, and it will probably surprise most people to know, that cardiovascular disease actually kills more women than every other cause of death combined in women.
Right.
That's astounding. Yeah, we often think, oh, breast cancer is a big killer in women. It's nothing in comparison to cardiovascular disease. Of course, we can't ignore it, and we need to continue the research, but we absolutely need to do a lot more about cardiovascular disease in women. And we know when women present to, hospitals, they're often not treated in the same way as men are treated. So that the high mortality in women is largely due to a lack of understanding and to an underdiagnosis and an undertreatment of cardiovascular disease in women.
Why does that happen? I mean, I think part of it is that it presents differently, right? And so then they're not appropriately treated.
That's right. It presents differently. So, women who are having a heart attack often present differently to men. And there's a whole range of different symptoms that people can experience if they're having a heart attack. Of course, the most well-known one is severe chest pain. But approximately a third of patients who are having a heart attack don't experience chest pain. And this is much more common in women than men. And men will often present to the ER and they will just say they've got, maybe they've got chest pain, they've got pain down their left arm, they've got pain going up into their jaw. They will usually only present with one or two symptoms. And because they're men and because they're usually presenting with symptoms that are clearly associated with heart attack, they're taken seriously. Women will often experience many more symptoms associated with heart attack. So they might go in without the pain in the chest and say, oh, my back's sore, and I'm feeling a bit lightheaded and I'm tired, I'm feeling a bit anxious. And often doctors just think, it's an anxious woman, go home and, just try and relax or whatever. And, they're not taken seriously. Mm-hmm. And I think it's a fact that the symptoms are sometimes different, but there's more of them. And sometimes the symptoms can be attributed to other health issues that the woman has as well. And even when they do an angiogram or something, it may not show up for women. When they test cardiac enzymes like troponin, there's a level of troponin which they say if the level is above that, then the person's likely having a heart attack. But of course, all that research has been done in men. Mm-hmm. And what they found is that women can have a much lower level of troponin and still be having a heart attack. But because it's not at that level that they've reached for men, then it's ignored. But women also have an underlying pathology to men, and this complicates it as well. Men will most often have coronary artery disease. So they have plaques in the large coronary arteries. And this is very easy to diagnose just with routine imaging, such as CT angiogram. The majority of women who have ischemic heart disease don't have the plaques in the large coronary arteries. They have the plaques in the microvascular circulation that feeds the heart. And this is called coronary microvascular dysfunction. And this is not detected on any regular imaging techniques like a CT angiogram. It's not detected if you have an ECG. It's not detected if you have, if you have just a normal stress test. It's not detected on any of the normal tests. So the only way to indirectly diagnose this condition is to do an echo stress test. And it's a little bit different to a normal stress test in that before the patient starts the exercise, they lie down, the doctor does an ultrasound on the heart, sees what's happening, and then the patient does the exercise in the same way that they do with a normal stress test. Then they lie down again, a second ultrasound is performed, and if there's any changes in the heart and how it's performing, if there's any areas of the heart that aren't working so well, obviously not getting enough oxygen under stress, and if the patient doesn't have coronary artery disease, then by default it's assumed that they have this coronary microvascular dysfunction. So in my opinion, all women, older women, postmenopausal women particularly, should have a stress echo test to rule this out. You won't find it with coronary calcium scores or any of those things. So it's difficult to detect, and there's no straight way to do it just yet. So, all this combination of factors is why we see women going to the ER, feeling unwell, and being sent home and then dying from a heart attack. Mm-hmm. And I heard a story on one of my trips to the US last year. I was talking about this topic, and someone told me that they had taken their husband to the ER for some reason, and during the time the doctor was looking at the husband, the wife got very fidgety, and the doctor said, "What's wrong?" And she said, "Oh, look, my bra's just suddenly feeling really uncomfortable. I don't feel right." And he was on the ball, and he immediately assessed her for heart attack, and that's what was happening for her. So a symptom just like that, which would mostly be ignored, particularly in a busy ER when you're not the actual patient. So it's difficult to detect, but it's something that does need to be taken very seriously in women. And I absolutely think it's time that we really stop thinking about heart disease as a male issue. And even now, physicians aren't on top of this. And just some research that was done in 2019 showed that when, women present to an ER, they don't get the same support as what men get. They often don't get the same the correct diagnosis. They don't get the treatment. And as a result, they have much poorer outcomes. And that's in 2019 that was still happening. This discussion, there was similar research done back in 1999, and recommendations were put forward. In 2019, we were still seeing exactly the same thing happening, maybe to a lesser extent, but it was still happening.
That's really fascinating, right? How slow sometimes science is to progress and understand that
it can take decades,
right,
for science to translate to clinical practice. Right. But just before we go on, I'd like to I think it's worth noting that, I've talked about the coronary microvascular dysfunction in women, but that can occur in men. Mm-hmm. And the same way, the coronary artery disease with the plaques in the large coronary arteries, that can also occur in women. But there is a clear sex difference with the expression, within the expression of the two conditions, where the microvascular dysfunction favours women and the coronary artery disease favours men. Sometimes people will have both of them.
And I think as we talked about changes in men and women, we also see sometimes that those underdiagnosed in racial disparities too, right? That more people of color are more likely to have these cardiovascular concerns too, and also have some of those underdiagnosed concerns.
Absolutely. And I also think the better educated people are, the better they are able to explain their symptoms to a doctor, and they might be more aware of what's possibly going on so they can express that. So I think you're exactly right. I think there's probably a bit bigger disparity, well, as big a disparity as there is between men and women in this regard, between, racial groups and socioeconomic groups in all developed countries.
Yeah, so I think in the message that I'm hearing is that we should be educating more on it's not just chest pain, it's many other things. And if you have that sense of kind of feeling off, right, you need to be, have that discussion, go to the doctor immediately, to look at that.
If you have a woman, and this happens to me all the time, I'll have a woman, middle-aged, postmenopausal perhaps woman, come into my clinic and we'll be talking. She'll say, oh, no, there's nothing wrong with my heart. I've had all the checks. I've had a CT angiogram. I've had coronary calcium score, all of that. Everything is absolutely fine. And I just feel like so bad and the bearer of bad news when I say, that's fantastic. That means you don't have coronary artery disease, but it doesn't rule out something else that you may have. And I strongly recommend that they go and have a stress echo test. So, they're so almost proud and they feel like, oh, great, that's something that's not going on. But it's not necessarily the case. So I think we have to educate, our patients in that way so that they've got more of an understanding of what's going on. Because often doctors aren't telling them that. My doctor, as good as he is, never said you should have a stress echo. I'm the one that said to him, I think I should have a stress echo. He said, yes.
Well, that's part of the key, right? We have to be our advocates for ourselves and work with people who are going to be willing to be advocates, right?
Absolutely. We have to help our patients advocate for themselves as well, give them the information that they need, because quite often we can't directly do it for them.
Right. So what is the physiology that's actually happening during the heart attack so people understand that a little bit more?
Most commonly what will cause a heart attack is when one of those plaques ruptures. And it could be in the large coronary arteries, it could be in the microvascular circulation. It will rupture, and then there's a whole chain of events that are set up that will, it's not that it actually blocks the blood vessel, but it causes such an inflammatory response that it will cause a heart attack. Now, there are some plaques that are termed as vulnerable or unstable plaques. And this simply means that the fibrous cap that encapsulates the plaque is quite fragile. It's not very strong. And these can rupture very easily. And it's quite often these unstable or vulnerable plaques that rupture during a heart attack. So there's a number of different things that can actually initiate the rupture of a plaque and bring on a heart attack. And some of these are the classical things that we think about might bring on a heart attack. So strong emotions and anger is a really important one in this regard. But even being, very excited at a sporting event can cause one of these plaques to rupture. Any sort of stressful event can do it. And it can be a good, what we would term a good stressful event, just getting very excited can cause it to happen. A lack of sleep can cause it to happen. Immune depletion or, respiratory infections can also bring these on. And we know that there's more heart attacks occur in winter when there's a peak in acute respiratory infections than any other time. And this is the same right across all developed countries. And in fact, in influenza pandemics, half of all the deaths that occur are actually due to cardiovascular causes, not respiratory causes. So that's something we need to be thinking about as well. Chronic inflammation will do it. Low omega-3 can also do it, and certainly it can, be involved in causing the vulnerable plaque. And all of these we can manage. They can be managed with lifestyle. They can be managed with herbal and nutritional supplements. So when you think about it, if only our patients would come to us preventatively and do exactly what we told them, we could prevent most of this in most of our patients.
So as we kind of wrap everything up, what are those key takeaways to make sure that we have patients with healthy hearts? What would we recommend for them to do on a regular basis?
Well, really, we have to eliminate and manage all the cardiovascular risk factors that I've spoken about, and many of them are lifestyle. So for most of us, it's totally within our control to make the changes. Quite often, we just need the will to be able to do it. We need to support healthy endothelial health, so the lining of the blood vessels, and microvascular circulation, and that's particularly important if somebody has that coronary microvascular dysfunction. So for that, I would use herbs like gotcha cola, ginkgo, grapeseed. Garlic is also very beneficial for the microcirculation, endothelial health, but it has an additional benefit in that it seems to reduce the risk of every known cardiovascular risk factor. And I always use garlic as part of my protocol for patients with any cardiovascular risk factor. Another thing we can do is try and prevent plaque formation in the first place. So making sure that there's no hypertension, making sure that the cholesterols, all of the different cholesterols are within the normal ranges. There's herbs that can help the plaque formation as well, and that's ginkgo and omega-3, but also supporting NRF2. I'm sure many practitioners are familiar with the NRF2, and the kind of herbs that can do that are things like grapeseed and ginkgo, which I've already talked about for the microcirculation and endothelial health, but also green tea, rosemary, Japanese knotweed, garlic as well. But importantly, particularly as a food, the cruciferous vegetables. So we can encourage people to be adding more of these vegetables to their diet, to be drinking green tea, to be adding garlic to their diets, using herbs like turmeric, rosemary, etc. And of course, we can give supplements that contain those herbs. If people have plaques already, we can help to stabilize them with gotcha cola. And there has been some research done in this. There's been a couple of studies looking at gotcha cola at stabilizing plaques. They didn't look at plaques in the coronary arteries. They looked at plaque, I think, in the femoral arteries. And they found that gotcha cola really stabilized vulnerable plaque. So, I think anyone who's aging, it's probably a good idea to take gotcha cola for a whole range of reasons. If somebody already has plaques when we see them, if they have that coronary microvascular dysfunction or coronary artery disease, then what we can do is improve the stability of the plaques with gotcha cola, but we can also try and help prevent the plaque rupture. So we can use things like echinacea or other immune herbs to make sure their immune system is strong, particularly going into winter when we see more respiratory tract infections, which we know are linked to an increased incidence of heart attack. We absolutely have to support the stress response and the HPA axis. And I've mentioned some herbs already, but ashwagandha, astragalus, eleuthero, great adaptogens, which help support the HPA axis to do the job that it should be doing in a better way. And other nervous system and adrenal support with St. John's wort, saffron, skullcap, valerian, romania, licorice, etc. We have a whole range of herbal supplements that we can use. And we also have a whole range of nutritionals that are very important for cardiovascular health. I've already talked about omega-3, but CoQ10 or ubiquinol, vitamin C, magnesium, etc. that's just the tip of the iceberg with what we need to be using, but they are some of the main nutritionals that we can be using. We absolutely need to reduce chronic inflammation, because that can cause inflammation in the blood vessels, which can then cause the laying down of the cholesterol and the plaque formation. So things like curcumin or turmeric, high potency willow bark extract are great, and there's a lot of research to show that high potency willow bark is beneficial in cardiovascular disease as well. So we do have a lot to choose from, and what we would be using, again, we have to think about, well, what's going on with this patient? Do they have plaque already? If they do we know if it's vulnerable or not? If you don't know, assume that it could well be and deal with that. If they don't have plaque, and they've got some of the risk factors, then we need to be treating them. So there's a lot that we can do as long as we can understand all the different options that we have in order to help these patients. And the sooner we get onto it, the better. So I think, all of this is, just extremely important, because I think we're probably seeing a decrease in cardiovascular deaths, probably in both men and women, more so in men. But that's due to medical treatments, and it's also, in many cases, better diagnosis. But it's still a big problem, because it's still the number one cause of death in your country and in my country, and I would say all developed countries. So we have the tools to deal with it, and it's something that we need to take very seriously in our patients, and we need to let them know they need to take it very seriously as well.
All those things that you've said today, it's just so important to be mindful of these things, right, in our patients, especially our women, but our men too, and, because they have slightly different ways that they present this information, and how we address that with them is so key.
That's right. It's our job to pick up things that they're not aware of, or that they're ignoring because they just think, oh, my blood pressure's only a little bit high, or I might only be sleeping 5 hours a night, but does that really matter? All of these things, we really need to really tell them the serious consequences of some of these things that can be taken very lightly. And then what they do with that, of course, is up to them, but it is our job absolutely to do that.
Right. Well, so we'll moderate our drinking, but we'll drink some really non-inflammatory teas and things of that nature to support our heart health, and take a brisk walk to enjoy the weather, to reduce our stress and support our heart.
Absolutely. And there's a lot of research coming out now on the benefits of being in nature. Now, I just laughed when I heard about that, because I thought, do we really need research to convince us of the benefits of nature? But it is good that they have the research. They can actually quantify the benefits of people getting out in nature on overall health, a whole lot of different components of health. So that's also what we need to do as much as possible. Even if you live in a big city, if you live in the middle of Manhattan, there's some really nice parks there you can go to,
For sure. Yes.
There's usually somewhere you can go.
So with that, I think we will go take a brisk walk in the lovely outdoors. Yours is going to be a lot warmer than mine is tonight, but I think we are almost at 35 here in Wisconsin. So,
hey, I'm in the middle of the day here, and the temperature here at the moment is, it's not too bad today. It's about 29 degrees Celsius. So that's not too bad, but we do have pretty high humidity. So I probably wouldn't go for a walk at this time of day.
Well, thank you so much, Berris, because I think we learn so much, and we really will think about our heart every day when we're talking to our patients, and really understanding what that looks like for each and every one of them, because it could be slightly different how things present. And we have so many tools in our tool basket to really help them to be successful and take care of their hearts.
That's right. Thank you very much.
Thanks, Berris.
Thank you to Berris and Sara for this important discussion about heart health and herbal support for cardiovascular disease. For more on metabolic health and herbal support, visit WholisticMatters.com. That's holistic with a W.